So I'm happy to speak with you all today on the impact of novel therapies on respiratory functions in spinal muscular atrophy and Duchenne muscular dystrophy. So some of my disclosures, I am funded by Sarepta for the study of novel therapies to treat respiratory pathology, dystrophy, and I'm NIH study AAV gene therapy for respiratory insufficiency and Pompe disease. So the learning objectives for today are to summarize the mechanisms that result in respiratory impairment and neuromuscular disorders, and to review current respiratory care management strategies, and to identify the FDA-approved and investigational gene therapies for SMA and DMD and their impact on respiratory function. So before I get into some of the management strategies, I just want to review a little bit of the control of breathing and how this is then impacted in neuromuscular disorders. So whenever we initiate a breath, this can either be initiated by our motor cortex, so we can tell ourselves, I want to take a deep breath in, and we do. But then when we're asleep and we're not thinking about it, then we have breathing centers in our medulla, which are important to keep us breathing while we are asleep or when we're not thinking about it. So these breathing centers in the medulla also innervate the upper airway and specifically the tongue. Every time we take a deep breath in, our tongue stiffens so that our upper airway is patent, and it allows the air to move past our tongue and upper airways and into our lungs. And so the phrenic motor neurons are also very important for breathing, and they are in the cervical spinal cord. And they are really important for innervating the diaphragm, which is the major muscle of breathing. And these become very important in some of these neuromuscular disorders because this is where a lot of the weakness happens and causes patients to feel very short of breath and eventually not able to breathe. And then finally, we have our intercostal motor neurons in our thoracic spinal cord. And this is very important for innervating our internal and external intercostal muscles, which are very important for breathing, especially whenever we're sick or we are exercising. They are the accessory muscles. And so then how does neuromuscular disease impact breathing? So in neuromuscular disease, the problems can occur at different parts of the motor unit. They can occur in the neurons which are located in the spinal cord. They can occur at the level of the nerves that are innervating the muscle, or they can occur at the neuromuscular junction or the actual muscles themselves, such as the diaphragm, the tongue, the intercostal muscles. And so diseases that affect the neurons are ones like spinal muscular atrophy. And so the neurons us as pulmonologists are usually concerned about are the ones in the phrenic motor neuron or in the control of breathing. They also affect the congenital myasthenia gravis is also a neuromuscular disease that is affected in the motor unit, and that's usually affected the neuromuscular junction. Diseases such as Pompe disease can affect the muscle, and as the muscle gets weaker, then the breathing gets shallower. And then finally, Duchenne muscular dystrophy is another example of a muscle disease that impacts the muscles and therefore the muscles of breathing. And I'm going to start off talking a little bit about Duchenne muscular dystrophy and how this impacts breathing. So Duchenne muscular dystrophy it's a devastating progressive X-linked disorder. It's caused by an out-of-frame mutation in Duchenne muscular dystrophy gene. Dystrophin is really important to maintain muscle structure. So as we exercise or as muscle contracts and relaxes, if there's no dystrophin, then the muscles eventually degenerate and cause more and more weakness. And so this is an example in here in these slides of mice from the lab that have Duchenne muscular dystrophy. So these mice have Duchenne muscular dystrophy, and these are control mice. And if you look here, the green is the dystrophin, and it keeps the muscle nice and round and well, and the structure looks great, so that whenever we do another stain called H&E stain, you see that the muscle structure is nice, and the structure is well put together and has no pathology that we can see. Whereas in the Duchenne muscular dystrophy mice, as you can see, that the muscles are all different shapes and sizes because of damage, and there is cellular infiltrate here, which are immune cells that have come in. And so this is a diaphragm, which is as I mentioned earlier, is the a really important muscle in breathing. So as that gets weaker, breathing gets a lot weaker as well. The other thing is 1/3 of children with Duchenne muscular dystrophy have CNS abnormalities. And as pulmonologists, we're not 100% sure yet what that means for breathing. But work from the lab has shown that the phrenic nerve, which innervates the diaphragm, has pathology in the mice with Duchenne muscular dystrophy, as does the hypoglossal nerve, which is really important for the upper airway patency. So Duchenne muscular dystrophy is a multi-system disease. As I mentioned earlier, about 1/3 of kiddos have learning and cognitive difficulties. There is dystrophin abnormalities in a few of them in the brain, which is a little bit less understood than that of the muscle. They also have decreased heart function and cardiomyopathy. And respiratory standpoint, they have weakened diaphragm, and they might require a ventilator, and sometimes they have aspiration pneumonia because of the upper airway issues. And then they have muscle mass weakness and inflammation and fibrosis, and their bones can also be affected. So because of all this, it's really important that we have a multidisciplinary clinic and a multisystemic approach to the care of these patients. And so we are as a pulmonologist, I'm part of the multidisciplinary clinic at Duke. And I'm going to go through a little bit of what I do in that clinic and why it's important to monitor the respiratory function. So we carefully monitor the respiratory function in order to optimize lung function. And this starts as soon as the patient is diagnosed, and we can start seeing them annually until we start seeing evidence of any kind of respiratory compromise. So we do something called pulmonary function testing every 6 months, and this can look at their total lung capacity. So how much air can they breathe into their lungs and breathe out of their lungs? And it's a good reflection usually of weakness of the muscles of breathing. We also look at the end tidal CO2, which is a really important measure of how strong their respiratory muscles are and how they're able to breathe out the carbon dioxide. We look at their pulse oximetry to check their oxygen saturations. We look at their cough peak flow, because as you can imagine, coughing is a very important defense mechanism. So that if food goes the wrong way or liquid goes the wrong way, or we aspirate something, if we're able to cough it out, it's going to keep it healthier. But as these patients get weaker, their cough peak flow gets weaker. And so we try and assess this every 6 months so we can stay on top of it. We also check the maximal inspiratory and expiratory pressures. And these are measures of the inspiratory muscle strength and expiratory muscle strength. And then about once a year, we try and obtain a sleep study, because normally if you're going to have any problems with breathing, that starts at night before it starts during the day. And so what we see is progressive respiratory insufficiency by about the 2nd decade of life. So as that muscle, the diaphragm, gets weaker, they have something called nocturnal hypoventilation, which results in increased carbon dioxide retention and nocturnal hypoxia. So at night, that means their oxygen level drops and they end up retaining a lot of carbon dioxide. Whenever we have a lot of carbon dioxide in our system, it causes us to have severe headaches. So these patients in the morning can have early morning headaches, and this is something that we ask about every time we see them. They also have daytime sleepiness and decreased energy. So our current therapeutic options, really, whenever they start having this weakness, is non-invasive positive pressure ventilation. So we do something called BiPAP. And so that provides inspiratory pressure as well as expiratory pressure. It's really important that these patients with muscle weakness do not just receive CPAP, which is continuous positive airway pressure, because that's good for keeping airways patent and during expiration, but it doesn't help them at all with taking air in. So it doesn't give them that positive inspiratory pressure that they need in order to take a breath in. So we normally start that once we start seeing weakness and once the sleep study starts showing there's any kind of carbon dioxide retention or any kind of decreased oxygen. Another very important device that we prescribe is a cough assist machine. So as I said earlier, once the cough starts getting weaker and these patients aren't able to clear their secretions, this cough assist machine gives a very strong inspiratory pressure and then a very strong expiratory pressure that sucks out the mucus. So we have an inspiratory setting and an expiratory setting. And then what we do as they get a little bit weaker is we tell them to end the cough assist on the inspiratory mode, and that's called lung recruitment. So it helps keep those airways open. We also start a lot of patients on airway clearance, just using this cough assist and sometimes using some nebulized medications just to keep their airways open and healthy, so they don't have to worry about lung infections or atelectasis. So as they get weaker still, eventually they need daytime support, and this happens with progressive respiratory muscle weakness, and then we call this diurnal hypoventilation. So they've gone from just this nocturnal hypoventilation to now diurnal hypoventilation, so during the day and night. There are some options that are available for these adolescents and young men once they get to this point. Sometimes they prefer to stay on BiPAP around the clock, but BiPAP sometimes doesn't allow them then to speak freely or eat or do what it is they like to do. And so there is an option called mouthpiece ventilation, which is an alternative to the mask. And what it is, it's a very sensitive mouthpiece that once they put their mouth to it, it gives this inspiratory pressure to really help them expand their lungs and breathe. And it's triggered just by placing their mouth on it. It's very sensitive. And then eventually some patients do decide that they would like to proceed with a tracheostomy with a ventilator in order to help them with breathing. In general, studies have shown that respiratory support is what prolongs survival compared to anything else. As you can imagine, if they're very weak and they can't breathe, giving them this positive pressure ventilation helps them survive longer. And so there was a study in 2012 that showed that those patients that were ventilated survived till about 27.9, 28 years of life, whereas the average survival for those not ventilated was 17.7 years of life. So the respiratory system is really important to try and target and try and treat. So that's why novel therapies really should also be looking at the respiratory system. And the goals of therapy for respiratory insufficiencies in these neuromuscular disorders are to either target the respiratory muscles, the nerves, or motor neurons, depending on where the pathology is. So for something like Duchenne muscular dystrophy, the respiratory muscles really need to be targeted. And so we want to look at the diaphragm, the bulbar, and the tongue muscles, the intercostal muscles. And then the question still remains, do we or do we not need to also target the central nervous system, given that 1/3 of these patients have neurobehavioral abnormalities? But it's unclear if this also impacts breathing. So one of the first FDA-approved therapies was eteplirsen, which was approved by the FDA in 2016 for those patients that were amenable to the exon 51 skipping. So out of the Duchenne muscular dystrophy population, about 13% of patients have these mutations. So eteplirsen is given weekly, but via IV infusion every week. And the initial trials that led to this FDA approval showed that dystrophin-positive fibers were present in 23% of the muscle compared to no increase in placebo groups. And over a 3-year period, the loss of ambulation was less at 16.7% in the group on eteplirsen compared to 46.2% in historic controls. So really what eteplirsen does is it bypasses this frame shift mutation. So if you look, this is a healthy Duchenne muscular dystrophy gene. Whenever it is translated, we get this nice mature mRNA and then a functional protein. But in this patient with exon 51 skipping, there isn't this puzzle doesn't fit together. So there's no communication. So it results in this out of frame mutation and therefore no functional dystrophin protein. So what eteplirsen does is it goes in and it says, hey, ignore this 51 and just go ahead and attach 48 to 52. And what ends up happening is that you get this restored reading frame and you get a dystrophin protein. It's shortened, but it is functional. And so that's how this works. And this became FDA approved in 2016. There's a few more that also have recently become FDA approved. Golodirsen was approved in 2019, and it's also for this one is for the exon 51 splicing amenable patients. And so the clinical benefit really for this was not approved. However, what they did show was that there was an increase in dystrophin in the biceps, 1 to 4% of normal compared to the patients that were not treated. Similarly, viltolarsen is also for the patients that have exon 53 skipping, and that's about 8 to 10% of boys. And this one was FDA approved in August of 2020. And then most recently, casimersen was approved for the exon 45 patients amenable to exon 45 skipping, which is about 8% of patients. So these are all weekly IV infusions. However, despite the fact that these have become FDA approved, the clinical benefits unclear, and the respiratory benefit has actually not been studied. And so the only one of those ASOs that have been studied is eteplirsen, which was the one that was approved in 2016. So like I said, data on the impact of exon skipping on respiratory function is only available in eteplirsen. The initial study was done in 12 patients where the respiratory function was assessed in eteplirsen and compared to untreated group. And it was actually compared to a historical control. And what they found was this is a historical control. So over time, the forced vital capacity, which is one of the pulmonary function tests that we look at, and it is what the forced vital capacity is. It basically shows how much volume of air patients are able to blow out, and it is a measure of respiratory muscle function. And so historically, the forced vital capacity decreased over time by about 4% in this study, whereas the group on eteplirsen had a decline of about 2.3% of their forced vital capacity. These results were then confirmed in a study of 71 patients on eteplirsen, and it showed that there was a decline when they were on eteplirsen of 3.9% compared to 6% of historic controls. So overall, the decline is attenuated. So there continues to be a decline, but it is not as severe as it was whenever compared to the historical controls. So that basically leaves us with still trying to find something that's going to improve the lung function, not something that decreases the decline. And so one potential therapy for this is AAV gene therapy. And so since the Duchenne muscular dystrophy gene is so large, it doesn't really fit into this viral AAV gene therapy. So there are 3 ongoing clinical trials right now looking at something called microdystrophin, which are truncated forms of the dystrophin gene. And this is an example of what AAV microdystrophin can do in the lab, in the mouse. So what we found was a month after injecting with AAV microdystrophin, the diaphragm had a pretty large percentage of positive dystrophin fibers. And whenever we assessed their breathing, there was an improvement, in the DMD mice that received AAV gene therapy. So there are ongoing trials right now for DMD gene therapy. There is limited data on what's going on with breathing in these trials, but every once in a while we do get a press release that tells us how these patients are doing. So one of these that came out in 2021 showed that the breathing test, the peak expiratory flow in 2 patients that were available for 2 low-dose and 2 high-dose patients, as well as untreated controls. Those that were treated had an improvement from 2.5 to 38.5% in peak expiratory flow compared to those that weren't treated who actually had a decline. And then whenever they looked at the forced expiratory vital capacity, which is also forced expiratory volume in 1 second, they found that there was also an improvement in the treated group from 2.8 to 15.5, whereas all the control patients had a decline of 8.7 to 17%. So this is promising because it actually shows an improvement in pulmonary function testing rather than a slow decline. So I'm going to shift gears just a little bit to talk about spinal muscular atrophy type 1 and just to talk about some of the novel therapies for this, which also have similar gene editing and gene replacement therapy as DMD. So spinal muscular atrophy type 1 is a leading genetic cause of infant death. What happens is the motor neurons have mutations in their survival motor neuron gene. And so basically that results in death of the motor neurons and decreased innervation of the diaphragm. SMN2 gene, or survival motor neuron 2 gene, is not lost, and it continues to be produced by these neurons in order to compensate for the lost SMN1 gene. These patients end up getting progressive loss of lower motor neurons, including the respiratory motor neurons. And if they're untreated, they end up having respiratory failure and a need for respiratory support by 6 to 9 months of life. Since this is a monogenetic disease, it really is an ideal target for gene therapy. And so if we look at what we talked about before for targets for novel therapies, in SMA, what we want to target with any novel therapy are really the respiratory motor neurons, such as those in the medulla, the cervical spinal cord, and the thoracic spinal cord. And so gene replacement therapy using AAV has recently been FDA approved for SMA. AAV is non-pathogenic or weakly immunogenic. It's naturally occurring serotype, and then there are also engineered serotypes to allow us a lot more AAVs to use. And so what happens when the AAV gene goes into the cell, it persists long-term without integration. So it leaves this viral DNA, episomal DNA, and it just kind of stays there in the cell and continues to produce the missing gene and the missing protein. And so the AAV gene therapy that's been FDA approved is gene. It's a one-time systemic injection that's given prior to 6 months of age. And actually now it's FDA approved for later too. So what happens is it's basically injected into the cell and it results in a healthy motor neuron. And so it's really important to be given prior to motor neuron death. And what we found is that respiratory outcomes are best if they're given prior to respiratory symptoms. And so that's what makes newborn screening so important for this disorder, because if it is administered in even the first few weeks of life, it makes a difference in respiratory outcomes. So the study that came out with the results of this AAV was in 2017, where 12 patients received the current FDA-approved dose, which is cohort 2 of this gene therapy. 20 months after treatment, all of the patients were still alive, compared to the historical control of 8% being alive at this point. And then the definition of it was having less than 16 hours of non-invasive positive pressure ventilation per day. Out of the 12 patients, 10 did not require non-invasive ventilation baseline, and 7 were still independent of any non-invasive ventilation at 20-month post-dosing. So this was pretty remarkable. And so a real-world study was then performed in Australia from 2019 to 2021, where they looked at 21 patients who were treated from 9 days to 2 years of age, and they were followed for about 15 months. 19 of 21 of these had received another treatment prior to the gene. And then the median age of cutoff was about 26 months. 7 infants before being treated had non-invasive ventilation at baseline. 5 of these continued to require respiratory support following treatment. 1 infant needed non-invasive ventilation even after treatment because of recurrent aspiration pneumonia. All infants with normal swallowing abilities and oral abilities at baseline maintained these skills over the first year post-therapy. And what was really fascinating was that 7 infants that had bulbar dysfunction at baseline, out of the 7 of them, 4 out of 7 didn't have any change, but there was actually an improvement in 3 out of 7. And 2 infants with severe swallowing dysfunction were able to start having PO intake again. So these data were really promising, but the patients that were treated earlier again did much better than those that were treated later. I'm going to shift to the gene editing therapies that are available for SMA. So it's an antisense oligonucleotide, like we mentioned before. It works by splicing the silencer, and it's not a permanent alteration, which is why these therapies have to actually be administered recurrently. So there's 2 that are currently FDA approved for SMA. Nusinersen modifies the splicing of the survival motor neuron 2 gene, which I had mentioned before, that compensates for the lack of SMN1. And there are 4 initial doses of nusinersen followed by a maintenance dose every 4 months. And that's, like I said, because this isn't permanent, we have to continue to administer this to the patients. The other newly FDA-approved medication for SMA is risdiplam. It's an SMN2 small molecule splicing modifier, and it's given orally. So in terms of what these do for respiratory function, we only know with nusinersen that basically studies of respiratory function showed a decrease in the rate of decline of FVC in SMA type 2, but not type 3 patients. And whenever sleep studies were examined, there was a drop in some of the sleep study parameters from 4.5 to 3.4, which meant their sleep was a little bit better in type 1 patients, but no improvement in type 2 and type 3. There is no data available for risdiplam, and this is something that we need to look into with the impact of risdiplam on breathing. So in conclusion, respiratory failure is a leading cause of death in SMA, DMD, and many other neuromuscular diseases. Gene therapy and gene editing are potentially powerful tools to treat these monogenetic diseases, but the impact of these novel therapies on respiratory function remains unclear. ASO therapy for DMD shows a slow decline. There is promising data from AAV gene therapy for DMD showing potential improvements in respiratory function. And then the FDA-approved gene therapy improves respiratory function in SMA patients when it is given early. So my research helps advance newborn screening research and NBS-TRN by really just realizing that longitudinal respiratory data is needed to assess the impact of novel therapies. It's also important for pediatric pulmonologists to be involved in a lot of these studies just to see the impact on breathing, whether it be in natural history studies or whether it be novel therapies. And then early therapy is really important to preserve respiratory function, which is why newborn screening is so important. I would like to thank patients and their caregivers, as well as the funding and my lab. Thank you.